We'll go ahead and get started with this this afternoon's panel. So welcome back, and hopefully we're all fortified from an early lunch, which was somewhat foreshortened by getting there too early, but hopefully you had enough time to enjoy it and socialize some. So this afternoon we're going to hear from a panel of speakers related to laws and policies for alcohol-impaired driving and alcohol use in general, as well as barriers and opportunities in regard to enforcement. What we'll do is we'll give each of our speakers a chance to give their presentations, and then we'll follow it up with questions and answers after they've had a chance to do that. So we have three guests, and the first we'll hear from Dr. Ralph Hingson, who's Director of the Division of Epi and Prevention Research at NAAA. Then we'll hear from Thomas Woodward, who's a retired lieutenant from the Maryland State Police. Something tells me he's going to talk a little bit about enforcement. And then we'll hear from Rebecca Ramirez, who is the Executive Director of the National Liquor Law Enforcement Association. So welcome to all three of you. Thanks for being here, and let me turn it over to you.
Okay, thank you. It's really a pleasure to be here and an honor to be invited to speak to you. As was mentioned, I direct the Division of Epidemiology and Prevention Research at the National Institute on Alcohol Abuse and Alcoholism. Before that, I was at Boston University, where Tim Namey currently works, and at the School of Public Health there, where I was Associate Dean for Research. And during that time period, I also worked a lot with Mothers Against Drunk Driving. I was on their national board and their vice president for public policy when we got zero tolerance laws passed across the country, and then with the .08 legislation. So I've been interested in this particular topic for a long, long time. Jeff Michaels this morning shared a slide that's very similar to what I'm going to show. This is a slide looking at the fatality analysis reporting system data on fatal traffic crashes that don't involve alcohol and those that do involve alcohol. And, Jeff laments that we haven't made a lot of progress lately. But actually, since the early 1980s, alcohol-related traffic deaths have been more than cut in half on a population basis. It's been estimated that over 300,000 deaths have been prevented as a result of reductions in drinking and driving, which is more than the combined impact of increases in safety belts, airbags, motorcycle helmets, and bicycle helmets. So really quite a remarkable accomplishment. That's not to say we can't do better, because a lot of European countries have lower percentages of their fatal crashes that involve alcohol, and Australia does too, than we do. So there's still some progress to be made. One of the reasons that we made the progress that we have so far is that most fatally injured drivers are tested for alcohol. And the fatality analysis reporting system that the NHTSA runs reports this data on the state level and on the local level. And when they don't have alcohol test results, they've developed a very accurate imputation system that they can estimate whether a fatal crash involved alcohol by the characteristics of the crash. We maintain at NIAAA, in my division, the Alcohol Policy Information System, where we track 36 different alcohol policies by state, by date of enactment. And it's a tool for researchers to use. We have a program announcement on doing policy research where we encourage researchers to look at how alcohol policies not only affect alcohol use, misuse, and related problems, but how it also may have, see if there are any spillovers to the use of other substances. When George Koob, our new director, came a couple years ago, the very first thing he did was he had us put the legalization of recreational marijuana use onto our system. So we're encouraging people to look at that. I think there's a debate in the literature about whether or not if states legalize recreational marijuana use, that there'll be a switch from alcohol use to marijuana use. And then there's another camp out there that believes that actually the two go together, and so that if one increases, the other will increase. Well, we think it's very important to do research to get an answer to that particular question. So these systems, the policy system and the fatal crash data, allow the evaluation of laws at the state level and at the community level. And scientists have created a whole roadmap of what kinds of interventions work, what kinds of state-level interventions, and what kind of multi-component community programs are effective in reducing alcohol-related traffic deaths and crashes. NHTSA every year publishes the annual data set. It's publicly available for researchers to use. And I'm pleased that they brought copies of their countermeasures at work, which is an outstanding document looking at the various alcohol policies and enforcement approaches that are effective in reducing alcohol-related traffic deaths. The FARS system also has enabled researchers, when they compare the FARS data to the National Roadside Survey data, to establish the risk levels at different blood alcohol levels, fatal crash risk. This is fatal single vehicle fatal crashes at 0.05 to 0.08, 12-fold increased risk for teenagers, about a 9 to 10-fold increase for adults. You get to 0.08, 32-fold increased risk of single vehicle fatal crashes for teenagers or adolescents, and over a 20-fold increased risk for adults. So that's very valuable information that MAD has used in its efforts to lower legal blood alcohol limits and set the zero tolerance laws. MAD is an incredible organization. I was really fortunate to work with them, and I felt it was sort of a life-changing experience to see these people who put in so much energy and effort to prevent other people from suffering the same kinds of pain that they may have in terms of losing loved ones. They personalize a problem. They have clear, measurable goals. They have a Rating the States program where they give every state a report card and the nation a report card periodically. They pay attention to research. They have researchers, many of whom we fund, on their national board and their public policy committee. And they're grassroots and inclusive. They point out that everyone can be affected by the problem, but also everyone can be part of the solution. And on this slide here in the corner, I have their magazine, a cover which had Jesus and Maria Carrasco, who lost their daughter Cecilia in a drunk driving crash, and they played a very active role in pushing for lowering the legal limits in the state of Texas. Basically, there are two major approaches to reducing alcohol-related deaths. First is to reduce hazardous drinking, and the second is to separate drinking from driving. And I'll be talking a little bit about what we know about how to do both of those things. In terms of the environmental policy interventions to separate drinking from driving, there are a whole host of laws, and I haven't given the full exhaustive list in the countermeasures at work, but these are major ones. The zero tolerance laws, the .08 criminal per se laws, all states have those. Administrative license revocation, where you can seize at the scene the license of somebody who refuses a breath test or fails it. Mandatory assessment and treatment laws, every state has those. Primary safety belt laws, primary belt law means that the police can stop a vehicle just because somebody's not wearing a belt. In California, when California adopted a primary belt law, a couple of our researchers, Jim Lang and Bob Vos, were doing community studies out there and roadside surveys. And so they did roadside surveys before and after. They found about a 20% increase in belt use. Belts cut the risk of injury or death in half if somebody's wearing them in a motor vehicle crash. But the biggest increase was with young drivers and with drivers driving after drinking. Why would drivers who are driving after drinking be more likely to adopt belt use in a primary belt law? Well, probably because they don't want to get stopped just because they're not wearing a belt, and then the whole cascade of drunk driving penalties will fall on them. Lower legal blood alcohol limits for convicted offenders, and enhanced enforcement, particularly sobriety checkpoints, very effective in reducing alcohol-related traffic deaths. It's not how many people get arrested, but if it's publicized and people feel that there's law enforcement activity out there, they'll be less likely to drive after drinking. In terms of policy interventions to reduce hazardous drinking, raising the drinking age to 21, reducing alcohol outlet density, and increasing the price of alcohol. Young people, I've heard David talk about this many times, young people have less discretionary income, so they're particularly sensitive to increases in price. Let me talk a bit about raising the legal drinking age to 21. I think that's a very important policy that's made a great deal of difference. And the National Academy of Sciences has played a key role in this. Back in 2004, the Academy's published a report on reducing underage drinking, a collective responsibility. I wrote the background chapter for that report on the magnitude of and economic costs of it. Dedicated my article to a young man named Terry Sterling, who was at Old Dominion University. As part of fraternity hazing ritual, fraternity members were asked to drink until they dropped. He passed out. One of the other pledges told the people, hey, watch out for this guy. I'm really concerned about him. They put him on a bench face down in a back room, and the next morning when they came to see if he was okay, he wasn't breathing. So what did the drunken fraternity brothers do? They cleaned up the liquor bottles and the beer cans for about a half an hour before they called 911, and by the time 911 got there, Terry was dead. Another pledge had to be taken to the emergency department. Fortunately, he survived the thing. In prevention, we often think, well, we ought to persuade people not to drink in dangerous fashions. That's the first place to go. What this underscores is that the environment in which the drinking takes place is every bit as important as the individuals. So we have to work on changing the environment as well. A year after that report came out, and it stimulated a lot of public discussion, Congress passed the STOP Act. I'll talk about some of those provisions in a minute. And a year later, or 2 years later, the Surgeon General issued a call to action to prevent and reduce underage drinking. At that time, there had been over 30 reports out of the Surgeon General's office on tobacco. This was only the second that dealt with alcohol. So we feel that this was an important step in the right direction that you folks at the Academy helped to have happen. The STOP Act required that all the federal agencies who deal with underage drinking convene and meet periodically. So we meet every month, either on the phone or in person. And it's the Department of Defense, Education, Health and Human Services, Justice, Transportation, Treasury, Office of National Drug Control Policy, Federal Trade Commission. All of these folks have efforts to reduce underage drinking. They also yeah, well, we in the federal government are into that stuff. Each of the 50 states were encouraged to develop similar task forces and to develop strategic plans. Supplemental grants were provided to communities to organize multiple city departments and private organizations and citizens to address the problem. There have been several national media campaigns, the most recent Talk They Listen by SAMHSA. SAMHSA has held over 8,000 town hall meetings to generate local concern about this. I can think of no area in the alcohol field where we have as coordinated an effort at the federal, state, and local government working across multiple departments of government and government working with private citizens to address a major alcohol problem. We raised the drinking age to 21 in every state, but we also have all these other laws, the zero tolerance laws, graduated licensing, use, lose, dram shop liability, social host liability, restricting alcohol outlet densities, and so on. So the states are undertaking many different, have passed many different policies to reduce the problem. Their implementation efforts, most states conduct underage compliance checks, and the other enforcement efforts, cops and shops and shoulder taps and party patrols and so on. At the time that the Surgeon General's report came out, there were 5,000 unintentional alcohol-related injury deaths under the age of 21. The good news is that number is now down to around 4,300. There were 1,500 alcohol-related traffic deaths in that age group. We're now down to just a little over 1,000, so we're making some progress. But there are many other problems associated with underage drinking: poor academic performance, cognitive deficits, risky sexual behavior, higher tobacco and drug use, overdoses, and secondhand effects of alcohol to others. Half of the people who die in crashes involving drinking drivers under the age of 25 are people other than the drinking driver. So there are a lot of people that are harmed. You know, when I think about, in my generation, probably the greatest public health success has been the reduction in tobacco use. Well, that came about because people realized that smokers don't just harm themselves, they harm other people. Well, I would venture that the secondhand effects of alcohol are far more immediate and far more dramatic and affect far more people than the secondhand effects of smoking. And that's what gives us leverage to go to state and local and federal government and demand that action be taken to protect innocent people from the mayhem that's caused by people who misuse alcohol. Nationwide, nearly 90,000 alcohol attributable deaths each year. Over 45,000 are injury deaths. Because they affect younger people, they account for twice the number of preventable years of life lost, about $250 billion a year in social costs as a result of alcohol misuse, and half the costs are borne by people other than the people who misuse the alcohol. They're borne by family members, and they're borne by federal, state, and local government. So the secondhand effects of alcohol are pretty dramatic and quite real. We know that young people drink less often than adults do, but when they drink, they're more likely to engage in binge drinking. About 1 million high school students binge at least 5 or 6 times a month. And as a group, they're much more likely to engage in behaviors that pose risks for themselves and others, to ride with drinking drivers, to drive after drinking, so they're more likely to be in crashes, not wear safety belts, so that when they're in those crashes, they're more likely to be injured. They're also more likely to carry weapons and guns, be injured in fights and suicides, risky sexual behavior, use other drugs. A third to a quarter drink and use drugs at school. It doesn't take magnetic resonance imaging studies to figure out if kids are drinking and smoking dope at school, they're not going to perform academically as well, and they're 3 times more likely to be earning mostly D's and F's. There's a lot of concern that the human brain is still developing until people are in their mid-20s, and that alcohol may disproportionately affect the developing brain. We know from the early cross-sectional studies that that if you look at alcohol-dependent youth compared to those who were not, there were decrements in memory and spatial relations and executive function and judgment. By the way, not only do those things affect academic performance, but they're also necessary to safely operate a motor vehicle. Well, initially the questions were, well, what came first? Was it the cognitive deficits or was it heavy drinking? We've now got some longitudinal research, and it looks like it's a little bit of both. Both cognitive deficits contribute to heavier drinking, but heavier drinking contribute to cognitive deficits. And we've now got studies that look at young people with alcohol problems and track them after having them enter treatment under supervised abstinence for over a month. And even after a month, while there's some recovery in the cognitive deficits, they still persist. And this is something that even if they ultimately go away, there's a tremendous opportunity cost if they're involved in serious traffic crashes, or if they don't perform well in school and graduate high school, get into college, or the college of their choice. We also know that the earlier people start to drink, the greater the likelihood that they're going to develop alcohol dependence at some point in their life. Bridget Grant at our institute did the first one of these studies in a national study. Since then, there actually had been studies of identical twins, where if one of them starts to drink earlier than the other, more likely to develop alcohol dependence. So even after controlling for genetics, this relationship holds. And we found that those who start to drink earlier not only are more likely to develop dependence, but they're more likely to develop it at an early age and develop chronic relapsing dependence characterized by more episodes and longer episodes of dedicated this to a young man. His mother came up to me at a Community Anti-Drug Coalitions of America meeting. He had an alcohol problem. They got him into treatment at age 16. Unfortunately, while in recovery, at age 19, he was struck and killed by a drinking driver. So treatment, I'm all for treatment, but we can't treat our way out of this problem. And we really, again, as I said earlier, have to change the environment. Early onset drinking has also been associated with other substance use problems, risky sexual behavior, car crashes, physical fights after drinking, unintentional injuries after drinking, and injuring oneself or other people in either car crashes or other ways after drinking, not just when people are adolescents, but it carries over into adult life. Dedicated that article to, I was organizing a conference on underage drinking, and I told one of the organizers that I like to dedicate my articles to people so we put a face on it. It's not just numbers. And tears started to well up in her eyes. She'd lost her son, Michael Timothy Wilder, 18 years earlier. I thought I was being sensitive. I didn't really appreciate, the enduring pain that some of these problems cause families across the country. So how are we doing? Well, this is the Monitoring the Future data on binging by high school seniors. And I'm happy to report, again, this is a National Academy helped to bring this to bear, that last year we had the lowest percentage of high school seniors binging than they've ever recorded in that Monitoring the Future study. Some declines in college age, but not in college, and even some declines in the college students. If we look at alcohol-related traffic deaths, this is 16 to 20-year-olds. There is no age group that's had a greater decline than the 16 to 20-year-old age group. An 81% decline per population in alcohol-related traffic deaths in that age group. And you can see this is the National Academy's report. Back here, 84, that was when Congress passed the legislation to withhold highway funds. The states didn't have that law. By 88, they'd all gotten the law. Reagan was the president at the time who signed the bill. When he signed it, he was, by the way, the ultimate states' rights president. He said, saving young lives is more important than states' rights. That's what he said when he signed the bill. And then this is the National Academy of Science report and the Surgeon General report. CDC has reviewed nearly 50 peer-reviewed articles on this. When the drinking ages were being lowered, the alcohol-related traffic deaths went up, vice versa. When the states raised the drinking age, 16% decline in alcohol-related traffic deaths in the targeted age group. Jim Fell, who we fund, worked at NHTSA, and he had Diane Weigel's position for many years. Did a study of over 20 years looking at the fatality analysis reporting system, looked at a whole series of potential confounding effects and other drinking and driving laws, and he too found a 16% reduction in alcohol-related traffic deaths associated with raising the drinking age. Interestingly enough, he also found that laws aimed at adults, like lowering legal limits, administrative license revocation, and safety belt laws, also had independent effects in further reducing underage alcohol-related traffic deaths. So if we tell kids, you're the problem, and we don't acknowledge that we're part of the problem too, they can see hypocrisy immediately. And so we have to make sure that all of our efforts are targeting all age groups. Norberg published a very interesting study looking at our national surveys and compared people who grew up in states where they could drink legally before 21. This looked at them when they were adults, average age 44. It turns out that those who grew up in states where they could drink before age 21 are more likely as adults to meet alcohol use disorder criteria and drug use disorder criteria. So there's a carryover benefit of raising the drinking age. Bill DeYoung, who I hired back at Boston University, wrote a great article in Journal of Studies on Alcohol and Drugs a couple of years ago, and the title says it all, Case Closed, Research Evidence on the Positive Public Health Impact of the Age 21 Law. a couple of years ago, I was invited, and actually David was there, to talk about this law as a success story, an American success story. There were 138 countries represented at that meeting. David spoke also and did a very nice job. NHTSA estimates 30,000 lives have been saved as a result of raising the drinking age to 21, 500 to 1,000 a year. Jim Fell has just published last year a study where he looked at 20 different laws targeting underage drinking and driving. He found 9 of them produced independent significant reductions. These are the laws. Together, he said they prevent about 1,100 deaths a year. Not all states have all of those laws, so if every state had it, maybe we'd save another 200 lives a year. Is it passing these laws enough? This was a study done right here in the nation's capital a little over a decade ago by the Insurance Institute for Highway Safety. They gave young people money and asked them to try and purchase alcohol. 98 times out of 100 in the nation's capital, people under 21 were able to purchase alcohol. So it's not just enough to pass the laws. There's a whole process of police and court enforcement, public education about the laws and why we have them, and how they're going to be enforced, that's necessary to create deterrence and changes in public perceptions, then ultimately reductions in drinking and driving and alcohol-related traffic crashes. And that's best done at the community level. This is a list of multi-component community intervention studies that have been shown to reduce alcohol use and underage drinking and driving, including some of the ones at the bottom down here, are starting to show these effects even in the hard-to-reach college community and in Native American communities. I don't have time to go over in depth on any of these, but I'll mention a couple. The Community Anti-Drug Coalitions of America and CADCA have developed a strategizer on how to conduct comprehensive community interventions, coordinate multiple city departments, have clear measurable goals, combine education and law enforcement, expand screening and brief intervention, use data to plan and evaluate, involve private citizens, be inclusive and involve young people. And I was an evaluator for what was called the Fighting Back program. It was the first program to combine expansion of screening, brief intervention, referral to treatment with environmental policy to reduce access to alcohol. We found that over a 10-year period relative to the 10 preceding years in the communities that implemented this program relative to comparison communities, we got over a 20% decline in alcohol-related traffic deaths. Dedicated that article to a young boy named Courtney Birch, 4-year-old, running to an ice cream truck when a repeat offender drinking driver slammed into him and killed him. Ann McCart at the Insurance Institute worked with Marshall University in West Virginia and the surrounding community with law enforcement to reduce drinking and driving, compliance checks, zero tolerance laws, legal drinking age, publicized by the universities. And they did roadside surveys where they breath tested the drivers, and they found that in the intervention communities compared to the control communities, they had reductions in the proportions of drivers with elevated blood alcohol levels. Not only are we able to do environmental policy and community interventions, but we can also intervene at the individual level, at the family level, school and college, web-based interventions, and I'll go through a few of those in a second. The U.S. Preventive Services Task Force says there's strong evidence that screening and brief intervention, brief counseling interventions are effective in reducing alcohol misuse when done in adult primary care. But they said there's insufficient evidence for adolescents. Well, they're going to revisit this because there's been some new evidence that's been coming out. Emily Tanner Smith reviewed 185 randomized trials looking at interventions addressing adolescents and those addressing adults. They found that these brief interventions were tied to significant reductions in alcohol consumption and related problems, including drinking and driving. And they actually found stronger effects for the adolescents than they did for the adults, and the effects persisted up to a year. Numerous studies of college students have shown it to be effective. Most recent, Scott Sheldon from Brown reviewed over 40 studies and found that the screening was so effective that they recommended that every incoming college student should be screened for alcohol. Because most college students have at least one university health service visit a year, that has a potential for population-level benefits. And studies have looked at what impact does screening and brief intervention and alcohol counseling have on drinking and driving. Stein-Fry did a meta-analysis of this and found that, yes, indeed, it can reduce drinking and driving incidents, most of it because of the reductions in alcohol consumption. Unfortunately, we have an implementation gap. We did a national survey a few years ago. 2/3 of 18 to 39-year-olds had seen a doctor in the last year, but only 14% were both asked about their drinking and given any kind of advice about what level of drinking poses risk. And those least likely to be asked were 18 to 25-year-olds, who are the ones most likely to meet alcohol dependence criteria and to drink beyond the low-risk limits that we recommended. I dedicated that article. I was speaking at MAD's 30th anniversary, and a woman came up to thank me for the work that I do. And before she could start talking to me, she burst into tears. She'd lost her daughter, Helen Whitty, 10 years earlier. She was out rollerblading when a car full of drunk teenagers skipped a curve and drove up onto the sidewalk where she was rollerblading and killed her. We did another study we published in Pediatrics a couple of years ago. 80% had seen a doctor in the past year. Over half were asked about their drinking. This is 16-year-olds that we looked at. But less than 1 in 5 were asked to cut down or reduce their drinking. And even among those who were drunk 6 or more times in the past month, only about a quarter were asked to cut down or reduce their drinking. So unfortunately, this is not on the healthcare professional radar screen, and we need to get it on the radar screen. Why don't they ask these questions? It takes time to ask them, time to respond, lack of training. We prepared training manuals to help people do this, lack of treatment referral, and there's some reimbursement issues. I don't know how many of you live in states that are in blue. Those states have laws on the books that allow insurance companies to withhold medical reimbursement for people who've been influenced under the influence of alcohol. So it's a terrible disincentive for providers to find out why are the patients, coming in to begin with. Fortunately, the states in pink have repealed those laws. And so the question is more screening going on there, and are they getting reductions in alcohol-related traffic deaths? We know that you can intervene at the family level. This is a Iowa Strengthening Families program. They implement that in middle school and see a 1/3 reduction in drinking to intoxication, even up to age 21. This is the MAD website called Power of Parents, put together by Rob Teresi. One of our researchers has done 15 randomized trials to show that if you provide parents with booklets about how to discuss alcohol with their kids, that there'll be less drinking. And then we've been very interested in college drinking. We had a task force of 25 presidents and 25 researchers. In 2002, we released a call to action to prevent college drinking, updated in 2008, mailed to every college president in the United States. We posted the 25 background papers on the web. There have been 450 million hits on that website since 2002. So people do care about these issues. Dedicated that article to Jonathan Levy, a student at Radford College. He and his buddies decided to go party hopping. They went to one party. On the way to the second, I don't know, they knew the driver had been drinking, but he had lost control of the vehicle, slammed into a car coming in the opposite direction. The car was driven by Margaret Mattson, who was a professor at the same university, left 4 kids. She died in the crash. Jonathan died. Travis Stedman in the rear seat was in a coma for a week, lost his left eye in the crash. Again, the people who misuse alcohol don't just affect themselves. They affect other people, and drinking and driving is one of the ways that they do it. We have prepared a college intervention matrix, where we published a couple of years ago, where we found that we looked at individually oriented interventions that are effective, and we looked at policy interventions that were effective. We looked at the costs and barriers and how you can overcome the barriers. I've been doing a series of reports on the magnitude of college drinking and driving. After the report came out, the problem continued to get worse until around 2005. The good news is we're now starting to make some progress. Reductions in binge drinking, reductions in driving after drinking, reductions in alcohol-related traffic deaths, and alcohol-related unintentional injury deaths. And I have just a minute or so I'll conclude by saying we've still got two concerns that we have to worry about. One of them is high-intensity binging, and the other one is the increase in drug use and driving. We have a paper in press, American Journal of Preventive Medicine, where we looked at two national surveys conducted a decade apart, nearly 40,000 in each survey. We asked in the past year what was the largest number of drinks that you consumed and how often did you have that much. We divided the people into those who were drinking at 1 to 2, 2 to 3, and 3 or more times the binge threshold. 3 or more times is 12 drinks on an occasion for a female, 15 for a male. If you drink that much, you reach a blood alcohol level of 0.3, even on a full stomach, 0.2. The average blackout begins at 0.22. The average death from an overdose for alcohol is 0.36. So this is a very dangerous level of drinking. And unfortunately, while we brought the drinking down in the underage group, and we're starting to make some progress with the college, overall, those who are drinking 2 to 3 and 3 or more times the binge level have increased over the past decade, not decreased. So we have a major problem here. And the people who engage in that very heavy drinking are, if you look at odds that we have here, 20 times more likely to drive after drinking, a third more likely to be in DWI crashes in the last year, 25 times more likely to be injured, 90 times more likely to have been to an emergency department in the last year, and nearly 8 times more likely to have been hospitalized. So this is a major issue that we have to address. The other is driving after drug use. The NHTSA's roadside surveys done in 2007, then again in 2013 and 14, show that driving after drinking, while it's declining, driving after drug use is going up. All states have 0.08 per se for alcohol, but only 19 states have drug per se laws. So there's a need to expand our legislative efforts to reduce drug use. We know that 8 states have legalized recreational marijuana use. In Washington state, they had a very good reporting of marijuana use involvement in fatal crashes, and they saw that after they legalized marijuana, it actually has gone up about 8 or 9% per year. Drinking in fatal crashes went down, but combined marijuana and alcohol use went up. So it's a very serious issue we need to be concerned about. There have been a couple of major studies that I brought copies of them with me in the Journal of Forensic Science that looked at experimental studies on driving and crash involvement, drug use and driving and crash involvement, and then also looking at epidemiologic studies. They find that there's risk of driving after increased crash risk after several different drugs, not as great as alcohol at 0.08, but the greatest risk is when people are both driving after drinking and driving after drug use. We found that the questions we use in screening for alcohol are good at identifying people who are also using other drugs. There were 3 major studies in JAMA in 2014, however, that found no benefits from brief interventions for drugs. But fortunately, Tanner Smith has just done a meta-analysis where she looked at studies that both address alcohol and drugs. Screening and brief intervention for alcohol only reduces alcohol consumption, no spillover to drugs, but if you screen for both, you can have reductions in both alcohol and drug use. None of these studies have looked at alcohol and drugs and driving as an outcome. I think we certainly need research in that direction. So let me end by saying, we have made progress in reducing alcohol-related traffic deaths, and I think we can make more progress. There are things that we can do. We have to be concerned about these increases in driving after drug use and the increases in very heavy binge drinking. I'll stop there.
Great. Thank you very much. Lots of good information. Thank you.